Hello, friends of the Retina Channel podcast. Welcome to episode 72 of this series. I'm your host, Dr. Kevon Kushan, and today we'll be talking about a uveitis study called the MERIT trial. MERIT trial investigated the effect of intravitreal dexamethasone, which is the standard of care as an intravitreal steroid, or intravitreal ranibizumab, or intravitreal methotrexate for the treatment of persistent macular edema in spite of control of uveitis in patients with minimally active or inactive uveitis. So these are patients who had control of the uveitis, but they had persistent macular edema affecting their vision. We have two guests. The first author of the study is Dr. Nisha Acharya. She is from the Proctor Foundation in San Francisco, University of California in San Francisco. She's a professor of ophthalmology there and director of the Uveitis Clinic. And the principal investigator of the study of the MERIT trial, Dr. Douglas Japps from Johns Hopkins University, and he's a professor of epidemiology and professor of ophthalmology at Johns Hopkins. I'm very privileged to have both of these distinguished guests on the podcast today, and I personally learned a lot from them and enjoyed reading the MERIT trial. And I hope this brings you value and you learn from this study as well. Well, without further ado, let's listen and watch these two wonderful speakers teach us about the MERIT trial. Hello, Dr. Japps.
Hello, how are you?
Dr. Acharya, how are you?
Hi, hello.
Welcome to the Retina Channel podcast.
Thank you for having us.
Well, I appreciate you, both of you, giving me your time. Busy days, busy schedule. Dr. Acharya, I know it's probably middle of your clinic in the West Coast. So it's a pleasure to really speak to both of you and talk about the MERIT trial.
We're excited to be here and to talk about it.
Fantastic.
Yeah, having us.
So before we start, I want to give our audience a bit of background about you and correct me if I'm wrong, just so people know who you're talking to. If that's okay, I start with Dr. Acharya first. You're based in the West Coast, University of California, San Francisco. You're a professor at the Proctor Foundation in the uveitis and ocular inflammatory diseases. You're the director of the Uveitis fellowship in the Proctor, if I'm not mistaken.
Yeah, I've actually passed that role on. I want to acknowledge I'm director of the clinic. And I was fellowship director for a long time, but Dr. John Gonzalez is the fellowship director which is great. He's a extremely dedicated teacher. So
fantastic. But you've done a lot of research yourself primarily in the field of uveitis, and you've done most of your education in the West Coast, except your residency in Harvard. But yes, you've done your medical school out West, and also your uveitis and cornea fellowship at the Proctor Foundation. So it's a pleasure really to have you on board. And then I'm passing to Dr. Japps. Dr. Japps, you're primarily based at Hopkins, and you're a professor of Department of Ophthalmology. Your primary appointment is at the School of Public Health. You're a professor cross-appointment ophthalmology, public health, and you have done a lot of research in the areas of ocular immunology, uveitis, the MERIT trial, obviously, that we're going to talk about, but some of the major uveitis studies you also on your belt. I'm not sure how much collaboration too you have done. I assume a lot, but ADVICE trial, the POINT trial, those are all major, really pivotal studies. So congratulations on being so active and influential in our field. It's a really pleasure to have you on board as well.
Well, thank you very much. And thanks for the kind introduction.
It's my pleasure. So the MERIT trial, just for listeners to know, I'm going to give them a brief overview. It's a study that was done in the middle of COVID. And so you looked at about 200 or so patients who all had either inactive, under control, or minimally active uveitis. It could be anterior, intermediate, panuveitis, postuveitis, some kind of uveitis with secondary macular edema. And they had some kind of treatment for that before, at least one steroid injection before that. And you were wondering if alternative treatments with methotrexate intravitreally or Lucentis intravitreally would change the course, would do better than the standard of care, which is primarily intravitreal steroids or Ozurdex in this case. So you had 3 arms, one at Ozurdex, and one was Methotrexate, and one was Lucentis. And then you have some retreatment criteria. For example, the Lucentis arm, they got 3 injections by default by 12 weeks, and Methotrexate has some retreatment, and Ozurdex some retreatment criteria at 8 weeks. And then you looked at them at 12 weeks to see what's the change, what's the primary endpoint, which is that change from your baseline central subfield thickness, and what's the vision change as your secondary outcome. So I'm excited to talk to you about it. So maybe I can start with Dr. Jabs about the background of this study. What's the reason you conducted this in the first place?
So we know from the MUST trial that even when you control the uveitis with systemic therapy, the majority of patients with uveitis and macular edema need at least one, and sometimes more than one, regional corticosteroid injection to dry up the macular edema. We also know from the MUST trial that at 1 year, rather at 2 years, about 40% of those patients have persistent macular edema. In other words, it might be improved, but it hasn't gone away. And then even if you can make the edema go away, we know about 40% relapse. So there's a huge problem with persistent macular edema and with relapsed macular edema. We know from some pilot data beforehand that a second corticosteroid injection often works better or adds to the effect of a first corticosteroid injection. So that might have been a reasonable approach. We know that when you give a corticosteroid injection, you do have the risk of elevated intraocular pressure. So finding treatments that didn't have the same risk might be advantageous. Mm-hmm. The POINT trial showed that if you're going to use a regional corticosteroid injection, intravitreal approaches are superior to periocular. Mm-hmm. And therefore, we decided to put patients into this trial who'd already had at least one intravitreal injection. And we had pilot data suggesting that methotrexate might be pretty good for controlling uveitis. And Anisha actually was instrumental in providing pilot data suggesting that ranibizumab might be good for uveitic macular edema. Mm-hmm. As you know, ranibizumab is better than corticosteroids for post-vein occlusion macular edema and for diabetic macular edema. And so there were some other theoretical reasons why ranibizumab might be a good choice in this situation. And so when you have pilot data suggesting these different options, you have at least a reasonably high rate of elevated IOP with what was considered the standard, namely a second intravitreal corticosteroid injection. We wanted to do a clinical trial to determine what we should be doing in this situation for the management of relapsed or persistent uveitic macular edema.
Maybe the hope was that these alternative treatments could potentially have a lower side effect profile compared to standard of care, which is intravitreal corticosteroids. So, Anisha, I'm just going to use this segue. What is this reason, maybe in the scientific background, for this persistent macular edema for these uveitis cases? I can think of my patients. I'm primarily retina practice, but I have some uveitis patients, and I'm thinking of like a patient with ankylosing spondylitis that she's got very quiet uveitis, but she's got this persistent macular edema. Is there any maybe secondary vein occlusion in these people that you found out they respond to ranibizumab? What's the really reason they get this uveitis, this macular edema, despite the uveitis being controlled?
So that's a really excellent question. I certainly don't have a definitive answer because I don't think anybody does. So I can kind of tell you some thoughts, and I think maybe Dr. Jabs can weigh in. We definitely see that it's a significant issue in the uveitis patient population, right? That many of them have recurrent or persistent edema. And as far as we can tell, their inflammation, in some of these patients, their inflammation appears to be controlled. I would say that it's always possible that we're missing ongoing active inflammation, right? Because we're only able to really detect inflammation on our exam and by our imaging tools. including fluorescein, ICG, autofluorescence, but there may be subclinical inflammation going on in some of these patients that's still driving the process forward, because we know that with inflammation, there's increased IL-6, there's TNF-alpha, there's increased VEGF. So it is possible that even though we think the patients are fully controlled, they may not be. That being said, it's also possible that, maybe they are really well controlled, but there possibly could still be persistent edema if there's just damage, if there's just so much permeability, if there's just been so many episodes of macular edema or macular edema that's led to damage, with basically just this kind of state of increased permeability, right, of vessels. So you're getting some degree of leakiness that's continuing on no matter what you do. That is, a possibility, right? Because we do see in some patients that they have, they just, they seem to be well controlled. So I don't know that we really know this. We do think that patients respond to treatment. Even when they have persistent edema, at least they respond, but it could be that there's other forces that are just driving it back again. If there's just increased permeability kind of at a new baseline, we may never be able to cure it. I'd be interested. I don't know if Dr. Jabs has any other thoughts on that.
I agree. I think there certainly is the possibility and probably the likelihood that a lot of this is just vascular damage where you get some repair, but you can't get full repair. And therefore, you're going to have persistent or recurrent edema. Regional corticosteroids probably have not only anti-inflammatory, but also membrane stabilizing effects. They're effective in diabetic retinopathy.
That's right.
Diabetic macular edema, where we don't think it's largely an inflammatory process. And so there are effects over and above what we see in controlling inflammation. Some of it may be subclinical inflammation we can't see. That always gets postulated, but there are no data to support that one way or the other. And indeed, it's probably not even a testable hypothesis with our current tools.
Yeah.
So I think, it's probably vascular damage, and that's why it responds. And while we focus now for this study in the MERIT trial on persistent and relapsed macular edema, we have to remember that in fact, given sufficient time, we can make most macular edema go away. And even with just the single injection or a couple injections in the first year or two, we can make at least 60% go away and probably more like 70 or 80% get better. So it's not like this is everybody, but it is a big problem, and it's an ongoing problem.
Well, thank you. Well, I'm going to keep you on the mic, so to speak. And you mentioned that about the inclusion and people involved and people who had already one corticosteroid injection. So just, in broad strokes, your treatment arms, the three treatment arms, could you tell me the patients and what they got and sort of how many injections they ended up getting in the study?
I'm going to go over that.
Sure. You or Dr. Jabs. Yeah, sure.
Yeah, I can maybe share some of those. I mean, I think that, so the trial, I think, you already presented in the intro what the three different treatment arms are. So just to kind of summarize the type of trial. So MERIT was a multi-center. This really was an international multi-center trial, centers all over the United States, Australia, and India, UK, and even Canada.
Canada,
quite a large network. Dr. Jabs has built the MUST network, and it's expanded more and more and more, which is great. It's really international. So it was multi-center, it's randomized, and it's a comparative effectiveness trial with three different treatment groups, right? So there's no placebo arm. It's really a very practical, real world kind of study of three different treatments, different mechanisms of these treatments. And each group was, there's equal allocation of patients to each treatment group. So let me go over the three treatment groups. You mentioned what they are. Okay, so the standard of care treatment is intravitreal steroids. And in particular for this trial, it was the dexamethasone implant, also known as Ozurdex. From the POINT trial, intravitreal triamcinolone and Ozurdex were comparable. So I think, we considered them to be pretty equivalent. But this trial, dexamethasone was the steroid. And then the other two treatments were the alternative treatments where Dr. Jabs mentioned there was preliminary promising data, but not more rigorous trial data, right, to really test out whether these were effective or not. And so those included intravitreal methotrexate, which has been used for lymphoma, right, for intraocular lymphoma. And there was preliminary data, published data, really from the UK, from Professor Lightman's group, on showing promise for it for uveitis and uveitic macular edema. And so that was the basis of including that. And then an anti-VEGF agent. And we did work with, we looked at different anti-VEGF agents, but for this trial, Genentech did donate the ranibizumab or Lucentis. So we went ahead and used that. And then as far as the treatment protocol, so all patients got their randomized treatment. And I'll just say one thing. I think we already kind of went over eligibility, but yeah, just to add to that. So of course the patients had to have macular edema. It had to be recurrent or persistent, meaning that they had to have it in the past and it needed to have been treated with an intravitreal steroid at some point. And then it needed to either come back or not have responded. Okay, so either persistent or recurrent. And then in terms of their uveitis, I think this is important as well. It needed to be really well controlled, basically minimally active or inactive.
Even on drops, if they could be on drops for that.
Yeah, we allowed a couple of times a day of drops if that was stable. We allowed immunosuppressive therapy as long as that was stable. So they had to have macular edema on stable therapy. But the uveitis, the actual clinical exam, imaging and clinical exam had to show that it was well controlled. And the reason for that is because, as far as we know and all the data that's out there, we don't think anti-VEGF agents treat inflammation or uveitis. They treat macular edema or permeability or, that type of thing. But we didn't want patients who had uncontrolled inflammation.
Yeah,
so
makes sense.
So that's the patient population. And then they were randomized to these 3 different treatment groups. And then, the treatment protocol really followed the way that these treatments are used in clinical practice to maximize their efficacy. So dexamethasone, so all of these treatments were given at baseline. And then dexamethasone could be re-injected at 8 weeks. That was the earliest that it could be re-injected. And, that's... there's actually, when the trial started, it was 12 weeks because that was sort of the thought that dexamethasone lasted
that long.
Yeah, but when the point trial finished, we really saw from that it's shorter acting in patients with macular edema. So the protocol was amended to allow injection at 8 weeks, which is done in practice. So as early as 8 weeks, but it really depended on having macular edema. So if macular edema was present, then they would be re-injected. Okay. Right. And the primary outcome, I should also mention, is at 12 weeks. So 12 weeks was the time point when we looked at differences between the treatment groups.
Right. And before we go to this methotrexate arm, do you have an idea how many of them or percentage of patients actually did get a second injection at 8 weeks, or most of them didn't, or most of them did?
Most did. I don't have the exact numbers here. I can get them for you. But methotrexate was really dependent on the presence of macular edema. So it was not a mandatory injection, right? They all got it at baseline. And then monthly, they were reevaluated up to the primary endpoint. And if they had macular edema, they needed to get re-injected. And so that most patients actually did get, I can kind of tell you probably pretty quickly, but, did get re-injected. And ranibizumab, it was mandatory injections monthly. So baseline and then 4 weeks and 8 weeks, because, as you're in retina, that's the way
standard of care. Yeah.
Standard of care is to do 3 injections. And so that was the treatment protocol. They had to have, they basically followed that. And I think all patients got their assigned treatment. And in the primary endpoint, it was 12 weeks. There were some crossovers, meaning some patients got other therapies that they were not assigned to, but it was pretty minimal until the primary endpoint of 12 weeks. So we do think that the 12-week data is pretty representative of what to expect with these 3 different treatments.
And the dexamethasone implant, you would allow 8 weeks injections, if I'm not mistaken, if needed. Yes.
Yeah.
Yeah.
Doug, yeah. Do you want to comment on that? That was a change because, when the trial was designed, it was thought that it would last longer.
So the trial was designed because of the COVID pandemic. It was designed a little while ago. And at the time, the prevailing thought was that dexamethasone implant was going to last 5 months.
Mm-hmm.
And so and then the point trial results came out and showed it really lasted about 3 months. Mm-hmm. And we know from other studies that with regional corticosteroid injections, you see maximum benefit at 4 to 8 weeks. So if there's persistent disease at 8 weeks, you're probably not going to get a lot more after that. So we allowed re-injection at 8 weeks instead of 12 for the study.
I love your graph and the article that shows after 8 weeks, you actually start to go down in terms of efficacy for dexamethasone implant. And I didn't know that. And you think it's 3 months, but really 8 weeks is the peak of it.
I think that now with point and merit, that's a really interesting secondary finding that's clinically.
Yeah, that was interesting.
Because, the trials were not specifically the trials that led to approval. This is a different patient population. It's uveitic macular edema. And I think that's why these kinds of studies are really informative and providing additional clinical information that's, really
Absolutely.
useful.
Absolutely. Dr. Jabs, let's talk about the results. So what did it show? Your study, what was the conclusion?
So I'm going to let Nisha present the results, and I'll take the interpretation of the results.
Absolutely. I'll go back to you.
Dr. Jabs can give you kind of that big picture. I think.
Yeah, I love that.
Important.
We'll go back to it.
That's a little complicated.
Take-home message. We'll learn about take-home message. Yeah.
He's really great with big picture stuff. He has kind of the insight of the broader view here.
Okay. Dr. Acharya, go ahead. The results. Yeah.
So the primary outcome was a reduction in central subfield thickness from baseline at 12 weeks. And so all 3 groups had a reduction from baseline, but they were significantly different. They were not comparable. So the dexamethasone group had I think it was a 35% reduction in central subfield thickness, and then ranibizumab 22%, and then methotrexate 11%. So they all had some benefit in terms of macular thickness, but when you do a statistical test, to compare treatment groups, dexamethasone was statistically significantly better
compared to either of the other 2 arms.
Comparing to either treatment group, it was P was less than like 0.001 or something like that. Very, very definitive result there for the primary outcome. And then of course, vision is really important, right? We all care about visual acuity. And only the dexamethasone group showed a statistically significant improvement in best corrected visual acuity at 12 weeks. It was about a line. So 5 letters on the HEDRS chart is 1 line improvement. And that was significantly, different than the other groups. And I think notably the other groups really, ranibizumab had just basically, very little, nothing meaningful, and methotrexate had nothing. So we didn't see visual acuity benefit with the other treatments.
Yeah. And so that I guess confirms the standard of care that, the intravitreal steroid. But I guess the big question that you also addressed in this article was the IOP issue.
Yeah.
So could you talk about that, please?
Yeah. So IOP, is obviously a concern with all steroids, especially steroids in the eye. And this is, and so we were obviously interested in those outcomes. So there were a number of different pressure outcomes, including a rise in IOP by 10 millimeters of mercury or reaching a threshold of 24 millimeters of mercury. And those 2 thresholds, elevation of 10 millimeters of mercury or reaching 24 did occur more commonly in the dexamethasone group. About 22% of patients had that happen compared to 2.6% in the methotrexate group and about 6% in ranibizumab. So that was significantly higher, but those were, relatively mild elevations, right? To 24 or 10 millimeter increase. When you look at reaching 30 millimeters of mercury, which is a more significant, a milestone or more significant, I would say, issue, right? To go to 30, that occurred more often in the dexamethasone group, but it was only 9% of patients. And the other 2 groups were about 1% or less. So, that is a difference. It wasn't statistically significantly different than 9% versus 1%, But I think that, it's there's a little bit more of a signal that there is some more pressure rise in the dexamethasone group. And also the dexamethasone group had to use more IOP lowering medications in order to control their pressure, but they didn't need surgery.
Not needed surgery.
Yeah.
Yeah.
So I think it's important to kind of consider that in your patient. I mean, if a patient has significant known issues with pressure, or they have, significant glaucoma that's not well controlled, this could be an issue for those patients. And there may be a need to obviously control the pressure, right? If you're going to go forward with steroids, because you don't want to harm anybody from that standpoint. But I would say that these are not huge, these are not, in my opinion, I don't think these percentages of reaching these high pressures are that high.
Yeah, I agree with that. I was actually impressed to see that the groups did well in terms of IOP. 20% increase, mild to moderate increase it's not a lot, and it's controlled with drops. And then I wonder if you had used triamcinolone acetate, it would be the same. I mean, the dexamethasone implant has a very nice profile for that, and that shows in your study.
So actually, the point trial, the point trial, the rate of IOP elevation with triamcinolone and dexamethasone were identical.
Oh, is that right? Okay. Well,
and
thank
so
you.
Really, with the point trial shows that the two of them, for all of the things you can think about in terms of improvement in macular edema, improvement in visual acuity, and IOP elevation, they look the same.
Oh, fascinating. Well, that's
and duration of effect. We all thought that the dexamethasone implant was going to last longer, and it didn't. So it's a pick'em based upon what's available.
Okay. Wow. Amazing. Thank you for pointing that out. Well, so that's great. So I guess we now look at the big picture, the Dr. Jab. So Dr. Jab, what should we remember from the study? If you want your audience to remember one thing from the study and take it to their practice, what's the take-home message?
Well, the take-home message is that if you have given an intravitreal corticosteroid injection for macular edema, and it's either persistent, doesn't resolve, or it comes back, you should give another corticosteroid injection. The other two treatments did not improve visual acuity at all. Methotrexate barely had any improvement in the macular edema, and ranibizumab had some, but with no improvement in acuity. So I think the other two, really, there's no evidence to suggest we should be using the other treatments at this time. Mm-hmm. The elevations of intraocular pressure, obviously we'd like to see fewer, but they were largely manageable. And surprisingly, or interestingly, they were consistent with what we saw in point. So we have two sets of studies showing that somewhere between about 30% overall, when you average the two studies, will get some mild elevation, and less than 10% get a big time elevation.
Wonderful. Well, this is very informative. I personally learned a lot from this study. Thank you for doing it. I think about like a perfect poster child patient I have, and I'll be giving her dexamethasone implant like every 3 months for at least like 2 years. And I just always wondered, is there anything else to be done, Mm-hmm. And thankfully her pressures are controlled, but she's obviously pseudophakic by now, like most of your study patients in the MERIT trial. But it's good to know. And this is just, I know we're running out of time. Have you noticed in your patient population, did the systemic control of uveitis with these anti-inflammatory agents, did that make a difference in who needs what, or how frequent they need the local control?
But there is some data actually out of the UK, out of Moorfields Eye Hospital, and they did a regional intravitreal corticosteroid injection for uveitic macular edema without concomitant systemic therapy. And at a year, they had about 100% relapse rate, very quick. Mm-hmm. And then they did a study where they used intravitreal corticosteroids and in patients who were on systemic therapy for their uveitic macular edema. And they had about a 75% reduction in the relapse rate at 1 year. And so definitely control of the inflammation with systemic therapy reduces the need for the use of adjunctive regional corticosteroid injections.
Okay, very good. And does it favor any particular agent over the others, like TNF inhibitors or any?
There aren't sufficient data to say favor one over the others. The impression is that it's control of the inflammation, inactive uveitis, that's important. Actually, there is a trial ongoing, the ADVISE trial, which is comparing conventional immunosuppression to adalimumab for uveitis. There will be patients in there with uveitic macular edema. We'll have grading on macular edema. We might be able to obtain some exploratory data on whether the older conventional small molecules are better to the newer biologic anti-TNF agents. But those data are not available yet. The trial is recruited, but still has a year to go of follow-up. So we're probably 18 months away from having any information.
I will add that will be great when that comes out, because, from our trial that we did, the FAST trial, which compared methotrexate to mycophenolate, not all the patients had macular edema. It was a uveitis trial, but the patients who had macular edema, the majority of them still had persistent macular edema, just with systemic steroid taper and antimetabolites, those two drugs specifically. So I think it will be really interesting to see if what you find in the ADVISE trial, with adalimumab, a TNF alpha inhibitor.
Wonderful. That's great. Anything we missed? Anything you folks want to add to this conversation?
You want to mention, though, that was the primary outcome time point. So
yeah. So that is the primary outcome. And the primary outcome point was chosen because that's when we expect to see the maximum benefit on macular edema, is in the 8 to 12 week time frame. There is additional data that goes out for 24 weeks, 6 months, largely for safety reasons, but also we could pick up any late signals on efficacy. And those data are actually being analyzed as we speak. And so stay tuned for part two of the MERIT trial results.
Very nice. I look forward to that. Thank you very much. Well, folks, thank you very much. Congratulations on doing the MERIT trial. You guys done a lot for our field, and keep doing what you're doing. And folks like me enjoy and benefit from your work. And thank you for all your hard work. And thank you for accepting my invitation to come to Retina Channel podcast.
Thank you for inviting us.
Yeah, it was fun.
Fantastic. Well, friends, this wraps up episode 72 of the Retina Channel podcast. I hope you learned from it and you enjoyed it. I personally learned from it, and I want to thank Dr. Jabs and Dr. Acharya for coming on the show and giving us their valuable and precious time to teach us about their study. I wish them well, and I wish them more success in publishing this new studies. A bit of a heads up about our next episode is going to be a surgical retina episode on the 10-year outcome of retinal surgery because of retinal dialysis, a retinal detachment due to retinal dialysis, a 10-year study by Dr. Rohowitz, London Rohowitz from Bascom Palmer Eye Institute in Miami. He's going to be talking about this study on behalf of their group. I look forward to that, and until then, I wish you all well, take care, and we'll talk later.